My name is Dr. Sarah Vittone, and I am pleased to be with you today. I'm one of the bioethicists at the Pellegrino Center at Georgetown University, and I'll be with you to offer some brief remarks on moral distress, which was highlighted in my work with Dr. Sotomayor during the pandemic. Our description of the entangled features of a novel moral distress experienced by patients became additive to the constraining features of moral distress experienced by the clinical staff. I have no conflicts of interest to declare, and your ideas and comments are welcome. I will be on the chat during the time of my presentation, so I look forward to our interaction. Moral distress is a core topic in clinical ethics, and while we continue to hear the term, how it has defined and evolved over the last 30 years is important. Moral distress has in some cases been slighted as an emotional distress. And there are similarities, but there are differences, and I hope to highlight that today. Ethics as a field is being called to respond to those in moral distress through various means. And I will close my remarks today on the entangled distress that my colleague Dr. Sotomayor and I described as pandemic-related, due to the unexpected result, a constraint of social isolation for patients, creating an unfamiliar moral distress for patients. To start our discussion, it's important to see how ethics intersects with moral distress. An ethical dilemma is a problem with two or more options with as yet unresolved solution. Moral distress is knowing the right action, but being unable to take it. Now, surely in healthcare, we expect there'd be struggles in life and death. It has only been of recent that allowing professionals to identify and address this distinct professional and personal distress has become important. Andrew Jameson first defined moral distress in his early work, focused on the experience of nurses as an inability to act according to one's own core values and perceived obligations due to internal or external constraints and uncertainty. By 1993, he exposed the lapse in bioethics to address moral distress. While clinical ethicists were addressing ethical dilemmas, once the solution or resolution had been found, the action was on the part of the medical professionals. Jameson said, addressing moral distress requires identification of social and organizational issues and questions of accountability and responsibility. The conversation on moral distress has since expanded to include all medical personnel. Freudenberger in 1974 described physician burnout as exhaustion resulting from excessive demands on energy, strength, or resources in the workplace, characterized it by a set of symptoms, including malaise, fatigue, frustration, cynicism, and inefficacy. Moral injury, further, is a consequence of failing to practice at the level of one's values and commitment. And this arises from unfamiliar, unexpected stress or circumstances, and was first described as a reflection on military, what soldiers had been exposed to, the perpetrating, failing to prevent, or bearing witness to, learning about acts that transgress deeply held moral beliefs and expectations. In 2000, Webster and Bayless defined a moral residue as that which leads each of us carries with us from time to time in our lives when we have faced moral distress and we have been seriously compromised, and this lingers and is additive. In 2009, Epstein and colleagues described moral residue crescendo. Each time a morally distressing situation occurs and resolves, especially when the person is repeatedly exposed to moral distressing events, the level of moral residue rises. Now, while some people do recover from these events, repeated exposure is additive and builds up over time. So this leaves us to explore what are the ethical challenges that lead to moral distress and what affects medical professionals' ability to act, and what are ethicists' obligation to this problem. Dr. Sotomayor, the head of our ethics service here at Georgetown, collects data on our consults, and these are the ones I'm going to share from 2019 and 2020. So these are our top ethical issues we found on our service in 2019, the top being refusal of care, the second being level of appropriate treatment, goals of care, followed by surrogate decision makers and patient capacity for decision making. So these are the categories that our consultants reported as the top issues in 2019. Now in 2020, we had about the same number of consults, right around 100, 105, but our categories changed just a little bit, with moral distress being highlighted as an identifying consult and the top consult that we saw in 2020, followed by level of appropriate treatment, goals of care, surrogate decision-making, patient's capacity for decision-making, and then informed consent. So while these specific ethical challenges are complex in themselves, and certainly responsibilities and obligations to act are present, how do these cause moral distress? And why can't medical professionals act as they want? Well, this comes from a variety of confounding elements. Constraints, including internal constraints, which might be things like lacking self-confidence, having fear to bring up something that might cause conflict, or maybe just an inability to cope. There may be external constraints. For instance, things like lacking collaboration in the healthcare team, poor communication, maybe restrictive policies, or lack of staffing, just lack of the number of people or lack of resources can be an external constraint. Uncertainty adds to this and has been well defined as an aspect of moral distress. This uncertainty was a huge change and an uptick over the course of the pandemic. These constraints and uncertainty certainly are additive to some specific elements, including professionals' lack of control of situations, lack of trust in process or their own colleagues, and lack of courage to stand up or to be able to do the right thing. In 2014, Thomas and McCullough published an article, A Philosophical Taxonomy of Ethically Significant Moral Distress. And they identified categories around individual integrity and professional integrity. Individual integrity is the basis for professionals in their action. It requires a sustained commitment to intellectual excellence, conforming one's judgment, decision-making, and behavior from a religious faith and their upbringing. Individual integrity requires sustained commitment to moral excellence, putting others first, such that protection and promotion of the interest of others produces durable values in yourself. Beecham and Childress address moral integrity as one of the 5 focal virtues. Moral integrity is soundness, a reliability, wholeness, and integration of moral character. Professional integrity requires a sustained commitment to intellectual excellence and moral excellence. Moral agency based on this moral integrity is important. And as Pellegrino said, integrity is essential to medicine as a moral enterprise. In 2017, a study by Austin and Saylor and Finley on moral distress in physicians and nurses, the impact on professional quality of life and turnover, was published. And I think this is really telling. Both physicians and nurses indicated the same top two situations causing the most moral distress. And I will read this. The first situation was following the family's wishes to continue life support, even though I believe it is not in the best interest of the patient. That's very constraining. And the second indicator was initiates extensive life support actions when I think they are only prolonging death. Again, these professionals are constrained by decisions that were made outside their control. These highest scoring situations causing moral distress, common in both physicians and nurses. I think that's interesting. To continue this further, how then do ethicists get involved and really start addressing moral distress? So I take the opportunity to talk about two authors in 2017. Cindy Rushton says, ethicists help build moral resilience by implementing a multifaceted approach based in mindfulness and self-care, as well as interventions to support and restore ethical competence. Austin, in the same year, said, ethics consultation, more broadly conceived, can be a major asset in ensuring that ethical practice is meaningfully supported and that moral distress is mitigated and that organizational environment is morally habitable. And I think bringing in the idea that organizations have an obligation here is important. There are many interventions that have been developed for resilience in health professions, and they have aspects of ethics included in them. Programs like Care for the Caregiver, the RISE program, Impact ICU, Schwartz rounds. These are ways that debriefing, that bringing the discussion forward in teams can address both moral distress as well as moral residue. Epstein and Hamric began what is called a moral distress consultation service, and they have some general strategies for addressing moral distress that I think are important. And they include things such as helping professionals to speak up, to recognize and name moral distress as their issue, to be deliberate in actions and taking accountable for their actions, helping professionals to actually see how they can act, to help professionals build support networks, to focus on change in the work environment to help preserve moral integrity. In addition, they design a consultative approach, and these are the particular aspects that they cite for their consultants. That they should listen and acknowledge moral distress. They should use a root cause of moral distress and help frame these situations for the professionals. Help name the constraints that are inhibiting ethical action. This is the value of the clinical ethicist in the team, to help put language on the ethical obligations that professionals so much find distressing when they can't act. Here at Georgetown, we are turned to 4 promising areas for building individual capacities for moral resilience through the Impact ICU program, where we use resilience training on ethical competence. We use an educational model. We encourage self-regulation and mindfulness, and also add in the self-care through consulting and listening, and facilitation. The original framework for this program was designed to enhance nursing communication with patients and families and other providers, and to improve compassion fatigue with self-care practices in the ICU. Starting in 2008 at the University of California, San Francisco, this program has been replicated and disseminated in academic, community, and military hospitals nationwide. Although the Impact ICU format was successful and is an effective program, gaps were found due to the lack of interprofessional approach. to fill the existing gap, the Impact IPE program, which we're doing here at Georgetown, was created. And this new multidimensional approach on education trains all levels of the interprofessional care team together so they can learn with and about with each other. This contribution for the development of the program includes ethics in a specific section, as well as psychology, to improve the facilitation and depth of the sessions. This is a program that I'm working on with Dr. Sotomayor, Beth Orell, Dr. Michelle Millick, and Heather Hartman, Elizabeth Griswold, and Jessica Walters. And we're excited to possibly show you some details on this next year at the KIE symposium. And finally, I want to include some comments about our experience during the pandemic and the associated Entangled experience. The pandemic has influenced moral distress, and it moved it to a more global experience where the overwhelming, devastating, and defeating aspects of the pandemic affected the constraining and uncertainty features of the experience of moral distress. In addition, because of the social isolation, the patient experience of moral distress was added. So we explored the idea that patients were suffering from their own moral distress and how that impacted the intensity of the moral distress experienced by the providers, the nurses, and the physicians. The paucity of research in this area with implications on patients' distress, decision-making, and the distress experienced by providers compels further investigation and analysis of this. We had case consults that included this unexpected added patient moral distress. When a patient experiencing an inability to participate in their own traditions and rituals deemed morally necessary for their salvation or transcendence due to COVID-19 policies and procedures in place, they experienced a moral distress because they could not act according to their own core values. And then physicians and nurses experienced an angst not to allow visitors necessary for resolving this distress. The clinical team is dependent on being more physically present and readily available, and that adds to the distress. Normally, physicians would be able to leave the daughter of the patient holding the patient's hand. But these days that has been not as readily available. And so this adds to the additional stress of the providers. The efforts to focus on the goods of the patient depend on the extension of the relationship, the common collective struggle that we share in the pandemic. Reciprocity and the relational aspects of the providers and the patients, organizations and their employees affect this experience. And we believe that it has affected moral distress during this time. So I will close by saying that with respect to moral distress, and especially the pandemic experience, we all may be in the same storm, but we are not in the same boat. We are experiencing the stress, the constraints, and uncertainty differently. And this is where ethics facilitation and support can be most impactful to restore resilience, mitigate moral distress, and help professionals to act. And these are my references. I look forward to our discussion.